So we don't have to fill it and get that attendance?
I think by clicking submit is when you get the attendance. Yeah, you can do it at the end.
Okay. So the first one, patient's blood pressure is 174/88. What do you want to do?
So we're talking about like common pages that a lot of you guys will encounter during intern year, on the floors, or when you're on at night. So like very annoyingly, just before you're about to sleep, like the nurse calls you like, this is the patient's blood pressure, 174/88. What do you want to do? Okay, we have one vote for B. What else? What do you guys want to do? He's gonna ask for vitals. Repeat.
Okay. What would you want to do?
Yeah, like, well, couple of things. Like, what is, you kind of want, the first thing would always be like, you want to get more information. Like, what was the context? Was this just like a routine blood pressure check? Or like, was this patient having symptoms and then you're checking the blood pressure? Has this patient's blood pressure always been like 170s/88? If that's the case, then you're just kind of like, you know, asking for the rest of the vitals is always very important. Like, you know, what are the heart rate, everything like that. And why would you want to ask for the rest of the vitals? What are you looking for? I'm going to put you on the spot where you're choosing your case. Yeah. Exactly. Yeah. Anybody else?
Yeah. Yes. So like basically you're trying to like think about like, is this just elevated blood pressure? Is this a hypertensive emergency? Is this like hypertensive urgency that I need to like act on that? So getting more information, like ask for the rest of the vitals, repeat the blood pressure is always like the right answer. And in terms of like what you're looking for, you're really looking for like end organ damage, right? So you're looking for whether there's sign of like heart failure, whether there's any sign of stroke, whether there's any sign of like, you know, like low urine output, like, you know, documentation, all that, okay? So
I feel like the main takeaway is like, oh, you have that.
So this is just provide like just like overview of like what you need to do. As you guys like correctly like mentioned, we check to see whether patient is symptomatic and look for like an organ damage. And it's always good to actually look at the home medicine to see whether any home antihypertensive medication might have been helped, because then it will help you to start a home medicine. When it's not like hypertensive, like emergency or urgency, it's rarely that you need to like really act like a acute situation. If there's no like immediate like treatment indicator, we can also monitor for now and see how it goes and just look for the trend. And if it is really like hypertensive urgency, that's basically a guideline that you can use. These are just like multiple like different things that you can do. So particular like things that you can overload. But really the main thing you're trying to see whether this is like life threatening. Okay. Any questions on that one?
Before we go on to the next one, is there any situation in which IV lorazepam would be your answer to give to the patient? Anybody? Pardon? Violent. Seizure. What else?
Cocaine.
Yeah, could be. Yeah. Alcohol withdrawal is a big one here to keep in the back of your mind. Okay. All right.
And the one thing that I forgot to mention is that you always rule out like pain, anxiety, like any other like possible underlying causes that is causing like the high blood pressure. So next scenario, patient is reporting 10 out of 10 pain. She already had her thyroid.
Stop antibiotics.
She has something else wrong there. What do you want to give her?
Clean up the list.
Good.
Alright. Okay.
All right. Anybody's gonna give
What
her
do you
another
think?
Tylenol? Just raise your hand.
She turns around.
Okay. Nobody wants to give another Tylenol. What about an NSAID? Maybe one or two. Okay. What? Anybody
it's
gonna
a-
jump
it's a-
straight to an oxycodone?
It's a conference.
You guys are all shaking your head now. Just wait until you come to like the night flood. Somebody said straight to the IV Dilaudid. Okay. The good stuff. Yeah. So anybody
sorry.
who's not gonna do
I
anything?
could turn it down. You can add it to the jumble.
Yeah, exactly. Exactly. Yeah, that's a really good point.
I mean, I have a feeling that she's going to do fairly well.
Nobody?
It's
Okay.
always a good one
Yeah,
when you
bad
do not
thing.
know what to do.
Your opinion.
I don't know. What would you do if you get paid on belly pain? 10 out of 10.
Well, yes, you need to go and evaluate the patient. I probably will ask for a set of vitals if it's like 10 out of 10 pain. And because it can just help you, you know,
It
like
does
if
seem
someone
fairly
is like
rapid,
really
though.
in pain.
'Cause remember, she was saying that she was driving on her own.
High tachycardic is probably
Yeah.
suggests that they're truly having pain. And then like you mentioned, you really need to see like what is the underlying cause of the pain is, and then take it from there. So there is no like right or wrong answer to this question. It really depends on like what the underlying cause is.
Yeah. Yeah.
Do you
we have
agree, Dr.
somebody from the MICU team says F, ultimate placebo for you guys on WebEx. Yeah, I think like you want to reevaluate. I think I've had a lot of times where the nurse will page me and there's a patient in 10 out of 10 pain. And then you go and see the patient and they're resting comfortably on the bed and they're sleeping, and then you kind of like wake them and be like, oh yeah, I am in 10 out of 10 pain. Like that's not 10 out of 10 pain. So always good to lay eyes on the patient whenever you get paged like that.
Yeah. So I did include this slide. When there's a lot of like different resources that you can use. One of this is actually you can find it in PMNI it's called. So what it actually like has it in there is like different dosages, different strength and stuff. It's actually quite helpful. Just in case like sometimes you were wondering what kind of like pain medicine I can give it to the patient. So that is a good like reference that you guys can use. Mr. J is agitated again. That gives you something. So what do you order from Mr. J? What would you do in this scenario?
Anybody want to call security? Yeah. All right. Go back to sleep. G.
Right.
A lot of the times, like, another big thing is we always encourage you to write like fail safes in your sign out. So if you know this Mr. J gets agitated at night, then say like on your sign out, it gets agitated at night, give something, whatever, or like don't give anything, it's like a really good way to kind of communicate with the night team. Like, you don't need to give anything. We're aware that this person gets agitated at night. Also, kind of like just the whole context is very important. Like, you'll get a random nurse page at like this all the time. And like, you kind of have to like dig through. So if this patient is here for alcohol withdrawal, you know, this person coming in agitated, like, might need, you know, something else. Versus if this is like a 78-year-old gentleman that is agitated at night because of like delirium or hospital-induced delirium in the elderly, then E would be the perfect option. You turn off the lights and just like leave them alone. So context is everything. Don't be afraid to ask the nurse for more information. Sometimes, like, one of the things as an intern is like, you want to act on all the things. You want to act on something really quickly. A lot of the times it takes a lot of nerve to just like take a step back, take everything into context, and then you can make a better decision that way. I feel like all of these can be right.
Yeah.
Depending
Home
on
security, I guess that you can, if they're really physically like violent, that is actually encouraging not to go into the room at all if like the patient is actually physically violent. But yeah, I think like any of these answers can be right. Again, it depends on the context.
Maybe not go back to sleep.
E is always like right.
Maybe not the go back to sleep part, but most of them can be right.
So this is just like another framework that you guys can use. Basically, you assess the patient to see like how acute this is, like something that has been going on for a while. If so, and usually the day team should have like, you know, a plan if this person gets like agitated and then what you should. Always like review any like possible medication that might have like cause the delirium. Then you might want to like stop that medication. Review vitals, pain. A lot of like old patients when they're in pain, you might actually become agitated. Just make sure there's no organic causes, like any stuff like urinary retention that can cause like delirium as well. And then like we mentioned, the intervention is really depends on the underlying cause. Always try non-pharmacology like intervention first. So here, if you're working in 3C right now, you probably have heard about like quiet night. It's basically let the patient sleep at night. That's always a good approach when you know that this is an old patient who comes to the hospital delirium. Just make sure the blood draw can be delayed to like 5 or 6 o'clock in the morning, so you give them like a good like night sleep. That always helps with like and take off like all the bias or tubes that is like not necessary for the patient. That again can reassure the patient. This will happen when you're on mental all the time. You get patient doesn't have a morning lapse order all the time. So what do you do?
Who's gonna put A? Nobody. What about B? Just BMP and CBC, you know, like routine labs. Everybody needs at least one of those.
I don't need one. C. Yeah.
People will pick C. Check sign out sheet, which indicates no AM labs. Yeah, that would be nice.
So again, it brings us to like, you know, the fact that sign out is so important because sometimes you do not know the patient because you're cross-covering. If you do have patients that you like intentionally did not order any AM labs because it's not indicated, it's a good, I think, sign out to actually put in there and say that no AM labs is needed, so that like the overnight person who got paged, at least like, you know, very straightforward, there's no morning labs needed. They can just let the nurses know. Yeah, C is always right. Do not like just routinely like order CBC BMP for everybody. We should really order tests that is only like indicated. Yeah.
I feel like I get paged like that a lot on step down.
Well, I guess it's because it's not me who signed out to you.
Yeah. Okay.
Mrs. Z wants something for sleep.
you guys gonna give?
So what do you prescribe? Anyone on A? B?
Melatonin in there. What dosage of melatonin will you give? What dosage will you give, Dr. Wang?
Well, it depends.
That's fair. 5 is always, I feel like 10 is too much.
Yeah, so if, I don't know, there's not, the evidence itself, like 1 to 3 milligram is when you use it for like a day-night like reverser. I know like people has been prescribed like 5 and 10, like milligram is really like pretty high dose.
Yeah. Yeah. Oh, and anything you do, don't order the extended release melatonin. Like, that's just it's non-physiological. Melatonin is not like should not be extended release, so don't order that one. Trazodone. Anybody? Ativan? Tender.
Yeah, I mean, when it comes down to like insomnia, again, you know, why are they not sleeping? And it's a question that you should ask the patient so that you know like what you need to do to help them sleep. And to be honest, a lot of them probably have like some home medicine. You know, a lot of people on trazodone for sleep. You know, as long as it's not indicated, you can just resume the home medicine. Otherwise, like, yeah, I think melatonin is pretty safe per se. Try not to use benzo, or you should never use benzo, especially in elderly patients. And he has something. What do you prescribe for him? So kind of a lot. It's interesting. A cup of coffee, maybe?
IV labetalol for your headache.
Yeah. Yeah, exactly. Yeah. Seems like Sandy already got the gist of it. Yes, you always should always see the patient and see what's going on. Again, like all of this like answer can be right.
Yeah. Any questions?
Tylenol, what is the max dose for patients with like liver cirrhosis? So we try not to use like more than 2 grams for patient that has like chronic liver disease. Okay, but for the acute liver failure and stuff like that, obviously we would just like try like avoid it completely. Fever. So yes, so for fever, another thing that you will encounter all the time. What do you want to do? What do you usually tell the nurses when they call you for like
Other than please recheck the Bible. We've done that one. So
SOFA score. Those are always like good to start with, so just assess like what the shot, whether the patient sepsis, and like Ben mentioned already, like whether this is actually the first reading or this has been like persistent, whether the patient has already been on antibiotics. So check the vitals to determine like hemodynamic stability. Because you do not want a patient that's like in septic shock just like lying in the back like for hours, and by the time you realize they're probably like so sick that they will holding it at time. Go see the patient and locate like common sources. Usually it's like pneumonia, UTI, having diarrhea, you need to think about CDA, any stuff like cellulitis. Always check the IV site to make sure there's no like any like check the legs to make sure there's no PET. Always think about PE as well. And if you really cannot find anything and this fever has been persistent, the other thing to think about is always the drug fever. But that again should be like exclusion. Guidance is about exclusion. And post-op is another cause of like so SIRS criteria and acute SOFA criteria two of like scores that you guys can use for patients with serious sepsis. Anything you want to add?
I agree.
Oh, QR code again. I guess everyone should have that by now. Like if you have done it in the beginning, and you're good.
Yeah, you only have to do it once.
Mr. S blood sugar was 500, and there's no sign still out of what you do. What would you like to do?
Mismanagement of your patient, Dr. Wang. You like,
Should I blame the day team?
yeah, blame the day team.
What would you guys do when someone call you? Like, I'm sure like you probably have encountered this already. Like sugar was very high, 400, 500, or even like 100. The nurses will like call you, and what would you do? Can you name a fund? Okay. Mhm. Yeah. Anyone? Like, do you guys have a system of what you would do? Okay.
Call the senior. I would do that.
Yeah, I mean, yes. So Nabil mentioned something, like basically you're trying to rule out. To me, like, everything we should rule out, like the most like life-threatening things first. Yes, you should like make sure the patient is not in like DKH or like HHS, like by looking all the vital sign and like consider like to do labs. And then Sandy also mentioned like how you will like titrate the insulin. So you basically look at the entire day. There's a few ways of doing it. One is that you can always check the patient's medication just to see what whole like insulin regime that they are on. Then you can always like resume them if it has not been restarted. Or you can look at the 24 hours trend to see how much insulin they need the entire 24 hours. You can divide it into like 50-50. So 50% will go to your long acting, and then 50% will go to your boluses. So when somebody is have diabetes, like when they are inpatient, we really try to use like basal bolus regime. So that is one way you can do it. If they just get admitted and you do not know what to do, the sugar has been like high, The other way of doing it is using weight. You can use like 0.5 unit and then times like the body weight. Again, that gives you a total number of insulin that is needed for the entire day. And you divide it into 50%, 50%. A lot of people do 10 unit at nighttime. Is more of like based on the weight, and 10 unit is just like is a sort of like lower dose. And we encourage you guys to use the diabetes like order set when a patient come in with a known history of diabetes, and all this should have like been like quick. And 19 will not recall if it's like 200 sugar, but yeah, again, we emphasize on the sign out and the using like the order set when you admit somebody. And the good thing about the diabetes order set is that when you order that, it actually comes with the hypoglycemia protocol. So if the patient actually goes into a hypoglycemia, the nurses can just like do like what is there like according to like the protocol itself.
I think so. I think like my algorithm for going through blood glucose of 500 is like you go through that chart and you kind of see like if this person's A1C is 15, then 500 is pretty much where they usually live at, and it's not something that I would usually worry too much about. I can maybe play around with either increasing the long acting or increasing the meal time. And the other thing is like that we want to harp about is everything is like about context. So 500 is this checked like right after they eat? If it is, then you expect the sugar to be higher. And so I don't know if I would act upon it directly. I would recheck it in a couple of hours. So context is like everything. So 500 in the context of what? What was the patient's home blood sugar? When was this checked? Like what's their home medication? So everything is like contextual. If this person is type 1 diabetes and admitted for DKA, and then that 500 is along the trend of coming down, then I would also be like, okay, we'll just continue current management.
So we saw is there are head check? Which of this do you want to order?
Who's on Cards Telly right now? What do you guys want to order? Okay. We're just like, what do you
right. Yes. So trust me, again, like whenever there's something happens, you always like try to think about it as essential. You know, like obviously, like Andrew was mentioning, ECG is home Bible. He's probably thinking about ACS, especially on card carry. You want to know like the chest pain, like where exactly it is. You get a history to make sure to help you with like differential diagnosis. Things that I do not want to miss is like ACS. What else? Like dissection that you do not want to miss anything like that. Could be like PE. So I always go into a system when I'm not sure like what I'm looking at. So chest pain, then you think of like cardiac process, pulmonary process, GI process. Are the like most common ones, and then MS process. When you think of like things like in stuff like differential diagnosis, it can help you what you want to do. So if you were concerned about like this patient came in for like an NSTEMI to begin with, hasn't had a cath like done yet, and then now saying that I'm having like this like elephant sitting on my chest, then obviously you will do like a vitals to make sure he's not in any shock that concerned about. Do an ECG and troponin is always right. Oxygen, with the vitals, it can help you to decide whether this patient needs any oxygen. Nitro is really, if this is a cardiac chest pain, but again, you need to make sure the blood pressure is not too low for you to give them nitro. IV lapidoral, I probably would not do that unless this is like hypertensive blood emergency that you need to think of what you need to get the blood pressure down. CTA is basically to rule out aortic dissection. That is my Morphine, ibuprofen, like the patch, again, those are just like almost standard that you're not looking at, like see the patient, they're not missing anything before thinking about like what you need. Okay, about hypertension. We sort of talk about hypertension. If someone like call you for a blood pressure of 85 or over 50, what do you want to do at this point?
Below. Transferred to MICU.
Yeah, what do you guys do?
Yeah.
Let's say a nurse call you. Hey, doctor, the blood pressure is like 85 over 60. What are you going to tell them or ask them? Okay. Okay. Anyone? Thoughts?
I feel like for me, if I get paged, like, this is the blood pressure, yes, like number one, I would always ask, like, how does the patient look? Because this is a really low blood pressure. If this is persistently low and it's abnormal for this patient, it might potentially require like MICU admission. So like low blood pressure is one of those things that it pops up for me that I would almost always repeat vitals and go see the patient. So those are like the two big things that I would do, and call my senior.
Yeah, because hypertension, when you think of like hypertension, you're worried about shock, right? So what type of shock do you guys think about? Well, there are 4 types of like shock that you need to think about, right? So I agree, you probably want to look at the trend first, because if let's say the blood pressure has always been low and there's like sort of like baseline, then you might not want to worry. You might not be as worried as much. And then you review like the other things that you should always ask is that whether the patient is symptomatic, like whether the patient is like having like episode, like syncopal episodes, chest pain, anything like that. That's suggestive of like there's like some organ impairment. Then you should always go see the patient in the setting of like hypertension. And review like blood pressure medicine to basically look for the cause of this like low blood pressure.
Put in
Yeah, so the key point here is that you always want to go like systematic, ABC. So go to the patient just to make sure that airway is okay, the breathing is okay, circulation is okay. Because whenever you're called for like a sick patient, you always try to address the basic, and then call your senior. Because if this patient usually cannot wait, you do not want them to be compensate themselves. You can always ask the nurse to repeat the blood pressure and using like the right cuff to make sure, and also like do a manual blood pressure to confirm that the low blood pressure. Like Ash mentioned, check baseline blood pressure and think of like possible like differential. So different causes of shock: distributed, hypovolemic, obstructive, and hypertonic. This should be like the differential that you would think of when you determine like somebody is actually in shock, because that helps you to like know like what to do next. But at this point, I'm sure like the seniors will guide you from there. Mr. B is in respiratory distress. What do you want to do? Put the tilt in. So for respiratory distress, I would see it as like you have to go and see the patient, just like hypertension. And yes, you will check the vitals again to make sure, to see what the pulse ox is like, what's the blood pressure. And I usually just call the senior at this point.
Yeah, like, well, as a senior, so, I mean, like, we would like for you to be there and see the patient. And then usually rapid response is always already there if the nurses have any kind of concerns about respiratory distress, like rapid response is already there, and there's like a continuous monitoring, like O2 monitoring already on. What would you want to order if you think somebody is in respiratory distress? Off the bat. ABG, yep. What else? Portable chest x-ray, yep. Be sure to order like the portable one, because if you order like the standard, it will never get done. Yeah.
Yes, that's possible chest x-ray, ABG. Check about how the, make sure like patient is still talking to you. The GCS is still like okay to using their own airway, because right now it's not good airway. Airway, I don't know what I'm yeah, you do not want to basically like if they get like hypoxia, like next thing and you'll call anesthesiologist back. So yeah, so chest x-ray, ABG, call your senior. EKG can you consider if you worry about something like that. So again, when you think about like differential, just go through system. It's just like a way to actually help you to get like some pulmonary kind of treat the most important differential. This one, Mr. T lost IVSS. So for IVSS, I don't know like whether you guys have encountered already. Some of you guys already have. We do have a picking that can help us.
During the day.
During the day.
Yeah. But at night, you might be asked to start like an IV line for the patient. How many of you guys are comfortable starting like an IV line or placing an IV line? Good handful. Okay, good. Yeah. Help each other out. You guys are more than welcome to try and start an IV line on a patient. There's always the vein finder that can help you out if you can't find it. And worst comes to worst, you can always call your senior. There's ultrasounds available at night. Then you can do an ultrasound guided IV.
And the one thing that you can always do is to look into the chart and look at the medication list, because you kind of want to decide, right? If this patient is going home tomorrow, it's not requiring like an IV like medicine, you can just say that we do not need the IV today and it's okay for a patient without the IVSS tonight. If the patient is on like one more dose of IV antibiotics and like you really cannot get an IVSS, again, just think of like you can try to use an oral medication if it is appropriate. So those are the things that you can potentially do if you cannot like find an IV. Okay. So the last one, as you are leaving the hall, just right before you leave the hospital, the family wants to talk to the doctor. What do you guys do? Or at night time when somebody calls you, or like a nurse call you, Mr. R's family wants to talk. Mm-hmm. Yeah, that's also the right thing to do. You review a little bit, you go and see the patient, see whether you can answer those questions. And if you cannot, that's also not Yeah.
So like, I mean, as a day team, which you guys are all part of, like during COVID times, there's very minimal allowance of like family visits and stuff like that. So what you can do to help out your night team colleagues is just like, call family, update them while you can, and just say like, hey, I can call you tomorrow or on a scheduled basis to give you an update. But usually the night team, there's a covering resident that's not too familiar with the patient. And so like, please direct all your questions to me as a day team member.
Yeah, when there is any like change in plans, just always let your patient know so that they won't get upset when it's like, oh, why did my like discontinue? Like nobody told me about it. And then your other night person, it's kind of not very fair to the night person to deal with that. So when there's change of plan, change in like medication and stuff, it's always nice to like just let the patient know the reason and why you did that, and like that is a plan for the night. That sort of like help the night person to get like less changes. I think that's all I got.
More QR code for attendance.
So this is really different overview, sort of like try to give you guys a framework, like how you will like all the like common pages. So again, like there are so many different ways of doing it, but it's just like a rough framework.
Yeah, and also like context is everything, but also you're never alone at night as an intern. You always have your seniors. So as a senior, I would really like it when my intern is faced with things that are like anything essentially, like hypotensive respiratory distress. You have to tell your senior, but like little things in here and there. And I like it when you kind of say, hey, this patient's blood sugar is like this. I've chart reviewed and it seems like she's chronically high. I would like to increase the Lantus to this. And it kind of just shows that you show initiative and kind of proposing a new idea and like managing, not just telling me, oh, this is what it is. What do you want to do? Mm-hmm. I know what I want to do, but I want to hear what you guys would want to do. That's pretty much it.
Yeah. Any questions at all? Dr. Wayne.
Have you guys encountered any kind of pages that you found difficult so far? Kind of like any pages that, the pain one. Yeah. Oh my gosh. Oh, yeah.
He probably will be like, I'm allergic to Tylenol, and it's more.
Oh yeah,
I'm only like the pain can only be relieved with
IV
that starts with
D. It starts with a D. How do you handle that?
Usually I talk to them. Like I would just say that I know this is hard to hear, like to listen to, but I'm here to have your best interest in mind. And I do not think like this medication is good for you, or like I usually start with that, like to address that. Like we have your best interest in mind. And yeah, I know that you're not going to like my suggestion, but we wanted to try to work this out together as a team. Somehow I think like so far it's been
Get out of my room.
bye.
Yeah. Also, like, don't take it personally either. If they don't want to talk to you because you don't want to give them like opioid medication, that's fine. You've done your due diligence. You've explained to them why it's not good for them. Just stick to your guns.
Yeah, I don't take it personally.
Yeah, don't take it personally.
Because you know that you have their like best interest in mind, and that's what it's been decided. Again, like this if this happened at night, it should really be like addressed like during daytime. And what happens, you can always discuss with your team and your attending and your senior, just to have like a plan together. Let's say he say no, like what are we going to offer him as an alternative, whatever pain that he has. And usually like patient, when you have like, a discussion, and you give them like an alternative plan, like
sometimes it looks a little better.
And also, if any patient becomes rude to you, like don't feel the need to stay in the room. Just excuse yourself and say, I see that you're in an agitated state right now. I can come back in 30 minutes to discuss kind of further pain options with you. But like, I don't feel comfortable with you like swearing at me in the room right now. So I'm gonna come back in like 30 minutes. So feel free to like leave the room if they're being very rude.
Don't give that to them.
Yeah, don't
Do not give any answer.
Held on.
Held on.
I am held on. Any other kind of scenarios that you guys want to talk about that you've had difficulties with?
Everything is okay so far.
Yeah, I feel like everything's okay then.
Okay.
Okay. Well,
Alrighty.
thanks for coming, guys. I hope this was helpful. All right. Okay.
Thank you.
You're welcome.